directly acting cholinergic drugs. Okay. So let's continue and a very happy good evening to everyone. Okay. Tertiary. There are two types. First, we have to discuss about tertiary and quaternary amines. Tertiary amines, which are more lipid soluble, and they are less polar. Quaternary amines are more polar and less lipid soluble. Yes, we can understand this because as quaternary amines we are saying there are four amine groups, so there will be more charged, they are more polar. Obviously, what are the compounds which are more polar? There will be more water soluble and less lipid soluble. Okay, so they can't cross the blood-brain barrier. As physostigmine is less polar and more lipid soluble, it can cross blood-brain barrier. Okay, neostigmine, pyridostigmine, hydrophonium, these are more polar and less lipid soluble. Okay, physostigmine, neostigmine and pyridostigmine has carbamide group. So we know that hydrophonium binds with the acetylcholinesterase enzyme very loosely. So its action is very slow, like 10 to 20 minutes only its action. After that, it can't it can't block the acetylcholinesterase. And covalent bond, when neostigmine is acting, it will show a covalent bond, means it the bond between the acetylcholinesterase and neostigmine is covalent bond. It is a labile covalent bond. Action will be 30 minutes to 60 minutes. Irreversible anticholinesterases, if we use alkyl group, they will form strong covalent bonds with the enzyme. Action will be greater than 30 minutes. Alkyl group, if it is detached, we can't reverse the action. So, if we want to reverse the irreversible anticholinesterases before the alkyl group removal, alkyl group degradation only, we should use the drug like pralidoxamine or meticolide. Aging or permanently loss of acetylcholinesterase due to irreversible blockade of acetylcholinesterase. Means if we irreversibly block the acetylcholinesterase enzyme, aging will be occur. If they block acetylcholinesterase in the brain, so patient will develop convulsions. Why convulsions are occurring? Blocking acetylcholinesterase means cholinesterase activity will be increasing. Choline will be increasing. There will be imbalance between dopamine and acetylcholine. So patient may be complaining of convulsions. Atropine, what it will be doing? Atropine is an anticholinergic drug. It will blocking the muscarinic receptor. If aging of this acetylcholinesterase occurs, pralidoxime can't be useful because alkyl groups are already removed. If alkyl groups are there, we can use pralidoxime. It is very useful. If aging occurs, there will be no alkyl group. So how it can't act? Pralidoxime can't act. It is unuseful. So physostigmine is a lipid soluble drug. It is less polar, so it crosses the blood-brain barrier and CNS stimulation is seen, ganglionic stimulation is seen. Therapeutic uses are GI motility and urinary bladder motility. This will be seen with bethanol and can be used in glaucoma, contraction of ciliaris muscle. Yes, we are and physostigmine and pilocarpine both can be used in angle closure glaucoma for a better effect. Overdose of atropine will be seen in atropine poisoning if we use more atropine. Phenothiazines are antipsychotics which are anticholinergic. Anticholinergic drugs main side effects are CNS stimulation increases and paralysis will be occurring. Too much cholinergic activity, CVS collapse will be occurring. Neostigmine, we can remember no CNS, means CNS action will be not seen because it is more polar, less lipid soluble, quaternary amine. So it is all less to fat, ganglionic stimulation, parasympathetic, neuroaffective sites, which is relatively less than physostigmine. At a neuromuscular junction, neostigmine is a better drug to be used than physostigmine. Uses of neostigmine in myasthenia gravis. What is happening in the myasthenia gravis? Autoantibodies will be generating against the own cholinergic receptors. Then this receptor and autoantibody complex will be taken inside the cell and this will be degraded, but acetylcholine receptors will be becoming less, and acetylcholine can't act effectively. Okay, this is happening. This will be leading to muscle weakness. Myasthenia gravis, autoantibodies which are formed, they will be acting on nicotinic receptors. Complex internalization will be going on. Neuromuscular junction, cholinergic channels will be less, and more physical works, more tiredness. Okay, it will be patient complaints of, if I am doing physical work I am getting more tiredness, like that they will be complaint of. So neostigmine, what it is doing, if we use neostigmine, acetylcholinesterase will be blocked, and more acetylcholine, less receptors, and power of muscle will be back. So here what is going on in this Lambert-Eaton syndrome or Eaton-Lambert syndrome, calcium channels of pre-synaptic junction will be less, because calcium channels blockade will be occurring by the autoantibodies. Then acetylcholine which is released, which is very less. Muscle weakness will be occurring due to deep tubocuranin. Neostigmine, if we given, it will be effective. Stimulate bowel and bladder. What are the side effects? Generalized overstimulation of cholinergic system. Pyridostigmine. Ambiphonium 9 to 7 to 8 hours it will be acting. Pyridostigmine, prolonged action. P for prolonged action. Amphiphonium 7 to 8 hours action. And Edrophonium will be, these are this will stimulate excessively the cholinergic system, so we can use these. If we use like prolonged, there will be prolonged diarrhea and prolonged urination, so these are urination, so these are side effects, means they will stimulate the bowel and bladder, and patient will excessively urinate and excessively pass bowels. So this should not be given in small cases. Like pyridostigmine, we can give in chronic myasthenia gravis. First, we have to differentiate between what is if he comes from myasthenia gravis or otherwise Lambert-Eaton syndrome. We have to know first. So, what we are doing? We are doing edrophonium test. Edrophonium test, which is superior drug for the diagnosis of myasthenia gravis. It is also can be known prominently as tensinon test. So, two patients came with some myasthenia gravis. So we have to first increase the dose of second patient will be coming with less antibodies, so autoimmune attacks. We have to increase the dose. Cholinergic crisis. Second person comes with cholinergic. First one with myasthenia gravis. So we have to find the difference. Means we have to do edrophonium test. If you inject edrophonium after few like after 20 minutes, 30 minutes, if the patient feel better and muscle power is back, then it is known as myasthenia gravis. If muscle power will not be back after injecting edrophonium also, then it is cholinergic crisis. In the cholinergic crisis, if we use edrophonium, muscles will become more paralyzed. Okay, so we can differentiate by what is myasthenia gravis, or if the patient is coming with cholinergic crisis, we can understand by doing edrophonium test. If you use edrophonium It will act for just 20 minutes. So it short period of urinary and bladder symptoms, urinary bladder and bowel symptoms will be seen. So patient is not that much means worried about those bit symptoms for 20 minutes. So we can use adrephonium for testing if it is myasthenia gravis or cholinergic crisis. If it is myasthenia gravis, after injecting adrephonium after 20 minutes, patient will become normal. Muscle power will be back. If it is cholinergic crisis, after injecting adrephonium, the patient will become more paralyzed. So, what is Alzheimer's disease? Alzheimer's disease, why it is occurring? Cholinergic activity with the cortex, cerebral cortex will be less. Before we are using to treat Alzheimer's is Trakinex. What we are using before this Tacrinex we are using, but this Tacrinex has more side effects. Those are strong hepatotoxicity, so we are using donepezil, rivastigmine, galantamine. So, what is cholinergic crisis? How we remember this cholinergic crisis? Dumbbells. D means diarrhea, U means urination, M meiosis, B bronchospasm, B for bradycardia, E for excitation of CNS and muscles, L for lacrimation, S for salivation, and S for sweating. These are caused because of cholinergic crisis. Okay, all. Thank you for listening to me patiently. Just we discussed what are anticholinesterases and what is myasthenia gravis. How can we differentiate between myasthenia and cholinergic crisis, and what are strongly crossing blood-brain barrier? How long affecting drugs, and that's it. What are the cholinergic side effects? So I think it will be helpful. Okay, thank you, friends, for listening to me patiently. Thank you. If you like the video, share, subscribe, like.